Good evening. This is Dr. Duke with Anxiety Disorders and Treatment presentation. I apologize again for the delay. After multiple computer issues and working tirelessly, my husband was unable to recover the lecture and with a final diagnosis of a bad hard drive. So graciously, he has let me borrow his work computer so that we could get the presentation to you guys. So welcome to week 3, Anxiety Disorders and Treatment. So of course, like I always say, and I mentioned last week in the presentation that I wanted to give you a little bit of the background, as we go, because you guys don't right now have a class, kind of a prerequisite course to prepare you to understand, kind of going through the diagnoses, what is the different criteria, what meets for what, why would it be diagnosis, why would you give this particular treatment for this particular patient. And so I wanted to go through and kind of go through what anxiety is, what the anxiety disorders are, and then we'll get into the treatment. So to start out, anxiety. Everyone experiences anxiety. Anxiety is a natural, and healthy feeling. We are supposed to have some anxiety. Mild anxiety is actually very healthy. It wants us to do well. It drives us to be successful, whether it's with a job or on test or in our profession. We want to do well. If we are parents and worrying about our young ones, you need some anxiety there. Anxiety, yes, can be severe, it can be worse. And as I go out throughout the semester, anytime that I mention an actual disorder, if you think about that, so that is beyond the norm, right? And there has to be some kind of social, occupational, interpersonal, some kind of functioning issues where we're not functioning as we should. And so for it to actually be disorder. So yes, when anxiety gets beyond to what is normal, can we have some very unpleasant type effects? Yeah, we may, have a headache, we may be sweating, have palpitations, tightness in our chest, our tummy is discomforted, be more restless. But, that being said, and yes, can it precipitate to panic, which we're going to get to in a minute? Absolutely, it could. But anxiety, I want, as you're working with patients and making sure you're educating them to understand, having some anxiety is natural, and it's a good thing. It also alerts us to when maybe there is impending danger, and also being able to deal with a threat. Getting those fight or flight organisms or neurotransmitters kicking in, that norepinephrine, epinephrine, to let us handle that fear or that stress. And so it's a good thing, and teaching and educating patients that there's maybe never ever a complete treatment, right? We're not going to disappear anxiety forever. It's probably going to be there, especially when you're predisposed to an anxiety disorder. But just we want to be able to find the right management and treatment so that it's more manageable, that you can deal with the symptoms and be able to work through a little bit easier and not let that anxiety take over you. All right. So back to our biological sciences, those neurotransmitters coming back into play again. 3 specific neurotransmitters associated with anxiety: norepinephrine, serotonin, and the GABA. And as we talked about, norepinephrine, we're like, oh, hey, if we don't have enough of it, we might be more depressed. Well, also, we can have an inadequate norepinephrine reuptake as well with anxiety. Maybe we have too much or we have too little. That might be throwing us off a little bit. Serotonin, again, maybe not having quite enough. And then the GABA, obviously, when we don't have enough GABA, then there's more likely a chance that we're having high anxiety issues. So let's start with one of the first disorders. So panic disorder. So reoccurrent unexpected panic attacks. A panic attack is an abrupt surge of an intense fear and intense discomfort. So it reaches a peak within minutes and usually symptoms are going to be 4 or more. So one thing I want to stop and say is, okay, a panic attack, and evaluate your clients, your patients when you're talking with them. Is there a trigger? Are they coming out of nowhere? Is there something that's bringing these on? A lot of times you'll hear that they are related to a trigger, and a lot of times it's for no reason. Maybe their meds aren't quite where we need it. They're not quite stabilized, still working through therapy and having panic attacks. Some people may call them anxiety attacks that are peeking through and coming for no reason. But patients may kind of describe them as, yeah, my heart's pounding out of my chest, my heart's racing, I can feel my heart beating. I can hear my heart beating. Maybe more shaky, tremor. I almost feel like I can't breathe. I'm closed in. I feel smothered. Chest pain. Sometimes you'll feel like they'll just bottom of their pit stomach and they're nauseous and distressed. They may have some numbness, feel like, and a lot of times you talk with patients with panic disorder too, it's especially in that moment, it's like you lose control. You don't feel like you have control over anything or feel like dying. A lot of patients will tell me, they felt like they were having a heart attack, like they swore, this is a panic. I mean, this is a heart attack, when it was actually a panic attack. And so that fear of this is it, I'm going to die, I can't do this. But one of the things for the criteria is not only do they have to have these attacks with, yes, experiencing, we said 4 or more of these symptoms we mentioned, but they've got to be at least a month or more. Also, did you worry? That's one of the things when I am interviewing patients and doing my evaluations is, do you ever worry or think about having another panic attack? See what they tell you. A lot of times it's like, oh my gosh, yes, I can never do that again. That's the worst thing. No, I just can't, I can't do that again. Or yes, ever since then, I have been more predisposed. I've been having more of these panic attacks, and it's just like that kind of opened up the floodgates, and I don't know what I'm going to do, and I'm isolating more, and I'm not going, and I feel like I'm going crazy. And then also see, is there a change in their behavior? So are they avoiding situations? Like last time I was in Walmart, I'm not going to Walmart again, or I was at a certain person's house, or certain exercising events, or certain things they were doing. And are they avoiding those because of that remembering and that fear of having another panic attack? Now, with panic disorder, there is with or without agoraphobia. So agoraphobia is where you've got this anxiety, this fear. A lot of times it's actually being a place or situation that you feel maybe that you could be embarrassed more easily, or that you have no help. A lot of times when I talk to patients, they explain it as literally one of the reasons they avoid going to public places is because if I were to have a panic attack or something happened, I'm stuck. I have no help. How am I going to get out of that situation? And talking with several patients too who've dealt with similar, having that person with them, sometimes they can get to the store and get places, but they know they've got help. But when they're by themselves, it presents a whole nother story. But there's usually, with agoraphobia, there's a marked specific fear or anxiety, at least two, it says by the DSM-5 criteria, 2 or more of the following 5 situations. And it could be public transportation, using the subway, just being open places, maybe large places. I've had patients who can handle small quick marts and up to the store, maybe to Publix, but cannot handle a Walmart. Being in enclosed. Some people, maybe I can't do elevators. I feel smothered. Like I can't be in a small room with several people, a theater and sitting close. It could be standing in line or in crowds. Day after Thanksgiving shopping is a big no for these people. That just completely precipitates and worsens their anxiety. Maybe it's being outside, and this is kind of really the sad one, but being outside of the home. Unfortunately, these are the patients that you see may be isolating and staying home and not getting out at all because of that fear of the unknown, fear of what is something going to happen to me? What if I get out and I fall? What if I make a fool of myself? What if someone's going to hurt me? Those multiple thoughts going through their mind. And so the fear has to be for diagnosis. It has to be out of proportion. And it usually obviously is going to provoke that fear, that anxiety type feelings. Has to be for 6 months or more. And then, like I always said, with any disorder, there's some kind of distress or impairment in their functioning for the diagnosis. So with or without panic disorder. So if you have panic attacks but have no fear of these situations, the transportation, the places, etc., then it may just be panic disorder. If you have panic attacks and their fear, maybe these things right here, being in crowds, being in places, being on the bus, leaving your house causes a panic attack, then you may be having actually panic disorder with agoraphobia. Social anxiety. Oh my goodness, this is probably one of the hardest things I think to treat. And I honestly, as far as we're learning psychopharmacotherapy, and in reality is social anxiety is probably more something that needs to be worked with a therapist. and doing cognitive behavioral therapy or talk. Medication there is very limited benefit. There is some relation and benefit as to with Lexapro is escitalopram. And I've actually personally seen a little bit of an improvement. I'm not going to brag as far as medications and working with patients. That's one of the most difficult things I have. And I really think talking with somebody and building these coping skills on how to manage this is better. But how do we know if this is social anxiety versus just pure anxiety? Well, there's got to be some kind of marked fear or anxiety about one or more social situations. So do they have a fear of conversating with other people, being around people they've never met before, afraid people are going to watch me eat or the way I'm drinking and they're going to judge me and make fun of me. I can't go out in front of people and do a speech. I'm not going to be the one who stands up in front of the class and has a presentation. I can't do it. Or maybe it's also just that whole fear of what are they going to think with me. I kind of picked this picture online because I want to make friends, but what if I say the wrong thing and they're judging me and oh, I've said the wrong thing, they gave me that look, or I see them talking, they must be talking about me. And that's a really, really hard thing to feel, and then to try to be social and make these friends. So unfortunately, it ends up with feelings that are always rejected, and so a lot of times too, if people aren't getting the help they need, then they're going to be isolating more. They're not going to have those social outlets that they need. So has to be a fear, anxiety of a social situation. Has to feel like are being worried negatively, right? Of being humiliated or embarrassed, as I said. And then also, you've got to prove, have you been isolating? Have you been avoiding these situations? I can't handle it. Have you left work because of situations, or got out of class because you couldn't handle it? It's your turn to talk in front of the class and you just had to leave. Those are all type things that are going to help you to diagnose whether or not. And again, for most of your anxiety disorders, it's going to be at least 6 months or more. And you're probably seeing that trend through the agoraphobia, panic disorder, and you'll see that here in a second for generalized anxiety. At least 6 months. So it's not just a one-time thing. I didn't speak in front of my history class and I can never do it again. I have social anxiety. You've had this recurrent issue before. So speaking of generalized anxiety, so these are my best kind of description of generalized anxiety are my worry warts. Those who just seem to always worry about everything, always mind going. Maybe actually even people may have told them or said you worry too much. Don't worry about those things. Of course, it's a whole lot easier for people to tell you that than to reality to be able to shut it off and not worry. But this is also, if we were kind of compared to the Disney Winnie the Pooh, this is Piglet. This is that deer, just worrying the cup half empty, oh gosh, but this could happen, and if I don't do this, this may happen, and kind of sometimes looking into the future, worrying about things instead of the here and now. Unfortunately, that worry can be so excessive that it's actually keeping these people awake. So generalized anxiety to be diagnosed is excessive worry for at least 6 months, okay? And they've got to have 3 or more of the following symptoms. And I just mentioned difficulty sleeping. And a lot of times they'll say, like, I am good, and then I'll lay my head down and I think what I should have done, could have done, need to do, would have done. Just next thing I know, look at my clock, it's 2 hours later. Oh my gosh, I have to get some sleep. And also it can also be stimulating to the brain because there's some kind of unconscious anxiety there that maybe I keep waking up throughout the night and then I get back to sleep and I play on my phone and I start thinking. Those are kind of some symptoms coming in. A lot of times with generalized anxiety too, because there's so much worry, people actually say they feel restless. Like they got to be moving. They got to be doing something. I can't settle. I feel on edge, maybe tense. One of the criteria on the DSM-5 was increased muscle aches or soreness. And people will tell you just never really feel like, and I'll actually ask patients, do you ever feel like you can just breathe, just relax? No. If they've got this going on, no, I can't. I always feel like I've got to go. I got to do this. This is always on my mind. It's hard to focus when you've got so much worry, when you have so much going through your mind. You have people that they can't focus, irritable. A lot of times when patients are describing generalized anxiety to you, they may have been in an okay mood for the most part, or maybe they were already feeling tense and just kind of on edge and have been hanging in there and holding it in. But like the smallest thing is what I hear. It's the small things. Just oh, you didn't put the dish up right, or oh, why did you park in the garage like that? You pulled up too far. I mean, it's just sometimes it's little things, and they'll go off about it because it was almost like the icing on the cake. That's it. And it's not that they meant to. It's not against that particular person. It's just sometimes they blow up. And unfortunately, when you have patients come back and they're like, that was on my spouse, that was on my kids, you're also seeing some guilt there because of blowouts that really weren't for something, or even unfortunately maybe work or friendships where it really causes a problem for them even more because they're blowing up over something small. So generalized anxiety, excessive worry, at least 6 months, restless, can't focus, get irritated over small things, still feeling tense, can have trouble sleeping. Obsessive compulsive disorder. Now, I think in talk, and there's just naturalness, but if you listen to people, and you guys maybe yourselves have said before that I hear people say, oh, I'm so OCD. I have to have things a certain way. I need my house clean. I got to have things organized in a certain order. So you can have obsessive compulsive traits. You can have obsessive compulsive personality. Does not necessarily mean you have obsessive compulsive disorder. Remember, we said disorder has to impair your functioning, right? So just because you do like your house clean, or you want your car to look a certain way, or your dress, or etc., doesn't necessarily mean that you have it. If you're having obsessive compulsive disorder, remember, it's got to cause some distress. One of the criteria right off the bat, so you're going to have a mixture of obsessions and compulsions, but one of the things I want to make sure I stress is at the bottom of the slide, it's going to, like, you're doing things, rituals, behaviors, whatever it is that's causing distress, it's taking more than an hour a day of your time. Can you imagine trying to get ready and get on time for work, and you get up, and you normally get up maybe an hour to 2 hours before you have to leave for work, and then you have to repeat these rituals? I mean, I've taken care of patients who, one particular, had to check locks, and had so many times he would have to go back and check the lock. And check the lock. Would leave that and like, nope. Did I lock the door? I don't know. And it's just counting. And I've taken care of some that count tiles and sidewalk blocks. And it's just, gosh, I mean, spending the time doing those things can delay you. So obsessive compulsive, let's talk about that. So it's a mix of having the obsessions. Okay, so these are the thoughts, right? So persistent, reoccurrent thoughts, urges, images, at some time, and it's causing distress, anxiety. Like you feel like this is bothering me. I've either got to do this, or why do I keep thinking about this? But it's constant, okay? You've tried to suppress it. You kind of distract yourself, but therefore it keeps coming. There's still that impulse, those images, and it's just, I can't quit thinking about something. The compulsion. Now I'm doing it. This is the behavior. So now I have the behavior, whether it's hand washing, ordering, checking, praying, counting, whatever it may be, where now it's actually causing me an issue because, okay, not only am I thinking it, now I've got to do it. And unfortunately, sometimes it's, what if I'm at work? What if I'm got to leave somewhere, but I just can't yet till I do it so many times. I've actually, in my job particularly, had a really issue with work and had lost several jobs, not being able to get there on time. So we had to really, really work with him for therapy. And even appointments, y'all. This is something that even appointments can maybe difficult for someone to be on time due to different obsessions or compulsions that the patient has. But it has to take at least an hour a day. And a lot of times the person's going to tell you, one of the criteria is the person's aware. They know that it is beyond, okay, it's excessive, it's unreasonable, but they can't help it. They cannot help that. You probably, if there's that TV show on hoarding and things like that. So hoarding is a type of also anxiety disorder, can fall under OCD. And as much as you think, well, what in the world, hoarding can be that, but in reality, hoarding, think about it, the obsession, right? They're thinking they can't let go of things, they've got to keep things, and then the compulsion, they are hoarding it's newspapers or magazines or shoes or whatever it may be. Can't let it go. Food in the refrigerator. Wow, seen some episodes. But so, it's not that easy. And one of the things for treatment, obviously we're going to talk about the medications and things, but one thing just so you know is it's not something that a person can just shut off. It's not something like, oh, okay, well look, that's not cool. You don't need to wash your hands 30 times a day. Tomorrow, not allowed to wash your hands. The anxiety will go through the roof, okay? We want to make sure that patients are the best treatment is to come up with some way to, hey, you've normally been doing 30. Let's work on maybe 25 tomorrow. Look, hey, you did 26. That's okay. Let's try tomorrow. Let's go back to that 25. Let's have a target. Something that is obtainable. It's realistic, and that's going to wean someone down from these rituals and behaviors, obsessions. It's not going to just happen overnight, and medications will help. But even with medications, sometimes patients will still have those urges and those things. It's just how are we going to work with this and deal with this? Post-traumatic stress disorder. You guys are probably we're flooded with hearing about this because of our vets coming home. Those are coming home from war, and unfortunately, we don't always get the best evaluation before our soldiers come home, and or when they've already come home, a best evaluation on the way of coming home and being released back home, and when you're already home, having the best of care. But this is not just our vets. This is our rape victims, our sexual assault, our maybe you're in a really bad car accident, losing a family member, witnessing a really traumatic event. So post-traumatic stress by the DSM-5 criteria, the victim has to be exposed to the actual or threatened death, serious injury, or sexual violence in one of the 4 ways. And so here you are. You're directly experiencing the event. Okay, maybe you witnessed the event. You learned about the traumatic event that occurred to a close family member or friend, and that was really traumatic for you. The description maybe of everything that happened. And then, or the experiencing the repeated extreme exposure to aversive details of traumatic events. And it's not necessarily just because I watched a TV show, just because I watched a movie that reminded me of somebody, but that maybe there were certain things that were pulling you to a traumatic event, reminding you of things consistently. Maybe it's a car accident, so you can't get in a car because of something you've been exposed to, certain things. But needless to say, you've got to be exposed or really witnessed the event, okay? So the DSM-5 kind of changed a little bit as far as how we diagnose the PTSD. We just kind of had straightforward, these were the symptoms, but now they've kind of gone out and, hey, well, here's certain criterion that you'll fall under. And so they're saying that the traumatic event is re-experienced in, and so you'll have where they may complain of nightmares and just replaying during the night, whatever event, the car crash, I unfortunately took care of a patient who witnessed, or came in after her father had shot himself. And so, replaying, walking back around the corner of that kitchen and finding her father. Intrusive thoughts of the event, they keep coming in, things remind them of that. Flashbacks, actually, again, reliving it, even in the middle of the day. This is not just at night. Marked emotional distress when exposed, traumatic reminders. And that is one of the big things, is triggers. I've had patients even say, look, it's even as a cologne, a certain smell, if it was a rape victim, certain way they looked. I've had a patient who really, really struggles to move on romantically because of being molested by her father as a young child. And so being able to trust the opposite sex after an unfortunate event or something like that. Having a strong physiological reaction. So that may be just that reminder again. Maybe I've actually had a patient who, gosh, her rape was in her 20s. She's in her mid-60s. Was checking out one day at the office and actually been fine, stable, refilled meds 3 months, sending her out the door. She had stopped by the secretary to reschedule, and a gentleman had just happened to walk around the corner that reminded her of her assailant, and it just threw her into a panic. Just thinking back at him, and it took her a while. We had to calm her down and get deep breaths and just kind of reassure, that wasn't him, and talk with her, and she ended up being okay. But there's that reaction, that reminder. Maybe you can't go down an alleyway anymore. You can't go into the back of someone's car or certain place that reminds you of the event. And so a lot of times because of that, I don't want to think about those things. Nobody wants to have those flashbacks, then they avoid. Unfortunately, maybe it's someone's house, but they are not visiting other family because of it. They're visiting their grandmother's house because an uncle has touched them, but not getting to see their grandmother or their other family. Maybe it's going out into a mall, or if it was on a subway train, or anything like that. And so they begin to avoid those places or those people because of the reminders of the event. There's also some changes in their cognition, their mood, putting them into more of a negative state, just thinking more negatively, more anxious, negative about the world. The world's out to get me. People aren't good anymore. There's only evil in the world. Maybe I've got to go in a restaurant, I have to see the door because I can't. Some people do that anyways, but especially after an event, watching out because you never know what people may do. And not being able to really feel positive, not really being able to look at things on the bright side because of so much negativity and things that have happened in their life, so much trauma. A lot of times you'll talk with patients and find out it's not just one event, it's, Lord forbid, it's multiple things in life that have happened. I've had a female patient from childhood, started as molested and physical sexual abuse as a child, to a bad abusive marriage, to losing a sister due to cancer. I mean, just multiple things can be very traumatizing for a patient. And there has to be also some hyperarousal, whether it's the irritable, restless, on edge, angry outburst, reckless maybe behavior, self-destructive, going out high speeding, doing things they wouldn't normally do, getting relationships that don't make sense. Hypervigilant, I mentioned, being on watch, alert all the time. Exaggerated startle response, someone coming behind you and boo, jump, but then in that response, maybe you come out and punching and you're kicking because of that. That is that reminder of maybe someone waking up and there's someone on top of you. Concentration issues and sleep. I mean, sleep because he has trouble getting to sleep, winding down their mind, maybe waking up frequently throughout the night from they're stimulated, or because of the nightmares, because they're so real, so vivid. All right, so one thing I want to say, I'm going to go back for just a second. So PTSD, here's these symptoms, but post-traumatic stress, in order to be diagnosed, you have to exhibit these symptoms for at least a month or more, okay? So PTSD, at least a month or more. So if we're looking at acute stress disorder, this is actually, so pretty much PTSD, right? All the symptoms of post-traumatic stress, however, less than 1 month. Okay, so this is someone who experiences 3 days to 1 month after a traumatic exposure, but then can kind of get themselves together, get back on track, and they do not continue to experience the same symptoms as your post-traumatic stress victim. This may be a new mother whose baby had issues or complications after delivery, had to go to the NICU, was able to come home. Mother still may have some distress from seeing the baby with breathing issues, or checking the crib and making sure they're breathing okay, or every time they cry and associating back to the hospital. And it may take some time, but maybe after the baby's a month old, they've been home, kind of going forward and being able to push forward and not let it bother them. This would be called more of an acute stress than necessarily post-traumatic stress. So, all right, pharmacotherapy. So I'm not going to go back into detail and re-educate on the SSRIs, SNRIs, TCAs, tetracyclics, MAOIs. We went over those last week for antidepressant lecture. But please know that those are a lot of times first line for treatment still for anxiety. Okay, so SSRIs are really still the thing that we use. They're not just an antidepressant. Remember, they also treat anxiety as well. They're holding on to that serotonin, right? Keep you from reuptaking too quickly. But things I do want to talk about and educate on is some a little newer is the benzodiazepines today, the non-benzo anxiolytics. And then we'll get into more when we get into more module 4/5, but some mood stabilizers / epileptic medications and atypical antipsychotics do and are increasingly being used to treat anxiety and post-traumatic stress, and do have some really good efficacy, actually helping a little bit quicker to tone down some of this panic and issues, and also being another option besides benzo to control our symptoms. So to kind of go through some of the treatments, we have panic disorder / phobia treatment, okay? So alprazolam or Xanax, clonazepam, Klonopin, fluoxetine, paroxetine, sertraline are all drugs approved by the US FDA for the treatment of panic disorder. Originally, the only two were actually Paxil and Xanax were the only two FDA approved for the treatment of panic disorder, and there's some more that's coming forward. Those were still kind of the key original drugs for panic disorder. But also, onto that saying what's been approved, there's also, again, experience I was just mentioning earlier, that there is superiority when it comes to SSRIs using the treatment to help with panic disorder and phobias. Also, clomipramine or anafranil, remember, is a TCA. So we talked about those, last week, that they do unfortunately come with more side effect potential. They're more drying, there's more anticholinergic type effects, and also more lethal in overdose. So they're just not used as often. However, there is some superior research when it comes to using anafranil for panic. So Buspar, and we're going to talk about that a little more, but that's our non-benzo anxiolytic. But buspirone has actually been suggested as a good add-on. It's not necessarily by itself. Sometimes we'll see it with kiddos a little bit when they have a little anxiety, a little Buspar added. But it's a good little add-on with your SSRI, SNRI, whatever they're on, to kind of help as an adjunct to help with the serotonergic properties and to keep the anxiety down. All right, generalized anxiety disorder. So, FDA approved for generalized anxiety. We've got the Xanax, Cymbalta, Lexapro, Paxil, Effexor, off-label, Celexa, Pristiq, Prozac, Luvox, Remeron, Lyrica, and Zoloft. Now, Lyrica, I'll tell you, as far as in psychiatry, I know I particularly don't normally prescribe that. I do leave that memo for the pain physicians. It's just adversely we notice that people can have a little less anxiety. There are some practitioners who are a little more free and use it. But it's not just something that is really, and that's been more of a newer kind of add-on thing, such as like Cymbalta getting pain approval a few years back. It's kind of Lyrica's like, it actually helps with the anxiety as well. So, but that is something that you may see used. OCD treatment. There is the standard approach is obviously to start with an SSRI, which is, you guys, like I said, first line for both anxiety and depression, or clomipramine. Okay. Serotonergic drugs actually have an increased percentage of patients with OCD who are likely to respond. About 50 to 70% of patients with OCD so likely to respond from a serotonergic agent. So that's pretty good. FDA, clomipramine, which I mentioned, anafranil, Prozac, Luvox, Paxil, and Zoloft. Off-label, where you can use Celexa, Effexor, or Vibrid. And remember, Vibrid is a little bit newer. It's a newer version of your SSRIs, but it came out in probably about 2010, 2011, so it's been out for a little while now. Unfortunately, though, patients usually will relapse unless they go on the drug indefinitely. And that's kind of the thing, because I think you're going to see that's one of the hardest things in psychiatry is I had 2 patients today that came back in for clinic and non-compliant, just, well, I was feeling better, and so you're going to kill me. I stopped my medicine. It's like, oh, and things have been worse, and I can tell a difference. It's like, let's start your medicine back. So that's probably one of the harder things, especially if there's a ritual and there's a obsessive thought about what is that medicine going to do to me long term, or is it safe that I take that medicine? Should I continue to take that medicine? That can be very difficult for someone to maintain compliance. All right, post-traumatic stress treatment. So SSRIs again, no surprise there. Effexor and Prozac considered first-line treatments and by the VA and the Department of Defense for the clinical practice guidelines for PTSD. Both are, yes, very, very good, especially Prozac. I've seen just amazing strides with PTSD victims and patients with Prozac. SSRIs and SNRIs can reduce symptoms for PTSD, especially those like with these clusters of re-experiencing, these avoidance hyperarousal can be very beneficial. And then again, the Buspar, there it goes again, Buspirone or Buspar, just another good little additive use to maybe also control some of the anger, anxiety, the thought overthinking with post-traumatic stress. All right, so here we are. I mentioned Buspar. So Buspar is an anxiolytic, right? It's actually a wonderful choice for those who have a history of substance use because there is no, risk, really, no physical dependence, no withdrawal, no abuse potential. It's a partial agonist for the serotonin 5-HT1A, so it's just acting on some of the serotonergic type receptors. very similar to that in a benzo. Of course, it's not directly acting on the GABA versus what we're going to learn with a benzo, but it is helping. You can see patients will use this anywhere from as needed to scheduled. I think for half-life reaction or reaction to time to hit is peak is I think half an hour to 2 hours. And so you might get some out of it, but I'll be honest, most of the time it works best if it is taken, and as you see down to the bottom, 2 to 3 times a day because of the short half-life like that. I think the half-life is about 2 or 3 hours. It runs out quicker, and so it is best to take it twice a day, every day. It doesn't interact as much with the alcohol, which is a great thing, again, compared to where we're talking about benzos here in a second. There's not sedation, there's no psychomotor impairment with it. It is not instant. It is not the one-time pill and you're great, though. Again, it's going to take a couple weeks to get in. I'm not going to say as long as an antidepressant, but actually I will teach patients very similar to expect 1 to 2 weeks before starting to notice the difference. And by 4 weeks when they come back and see me, we may have a little better idea of what we have. But most people, again, to get the most benefit, need to take it twice a day, 2 to 3 times a day, every day to see a difference. All right, clonidine. So clonidine is another good option for just, again, an alternative to benzos. Clonidine you're going to see prescribed, obviously, for blood pressure. If you've been on the nurse on the unit or family practitioner, you may be using it to treat your hypertensive patients. Of course, I know in the unit, when every time we'd give a clonidine, it's like, okay, let's get the patient to bed. They may be a little sleepy. Let's put your feet up and kind of rest, because it can be sedating. So a lot of times you'll see clonidine, especially with kiddos who deal with ADHD and have a problem settling and getting down and rested for bed. You'll see it prescribed at bedtime. There is some research related to that with post-traumatic stress and nightmares. But with PTSD victims with clonidine, we can actually use it even twice a day. Very helpful for the anxiety in itself. It just kind of keeps more calm, less likely to impulsively react before thinking. So it's helping with impulsivity. Again, helping with ADHD as well, if there's some impulsivity for kiddos. And it's also helping with these post-traumatic stress victims, helping with their anger, their anxiety, their worries, just kind of keeping things a little bit more calm. So off-label things is obviously, yes, PTSD, social anxiety, Tourette's. So where clonidine is also beneficial in those kids who take stimulants. Sometimes you may see the sister drug, guanfacine as well. You'll see it added on to help with, as people say, tics per se. So if we have a little movements, blinking, etc. from the stimulant itself, if the stimulant's bringing out a tic disorder, then the clonidine or the 10X can be also beneficial for those. So we use it there. Substance withdrawal, it's been beneficial with, especially with opioid and alcohol withdrawal, menopausal flushing, and even pain, and with cancer patients. So that's really, really interesting, as many things as it has. But most commonly, again, with the kids and with hypertension, and again, coming more with our post-traumatic stress bits. All right, I really like propranolol. So propranolol, I definitely wanted to make sure I touched on. So it's, of course, a beta blocker, right? Lols are beta blockers. It's just an old blood pressure medicine, but physiologically calming, right, to the heart, the pressure. So psychologically also can be calming. Where I see propranolol most often given, can it be twice a day, every day, once a day, every day? Absolutely, yes. More often, though, I see it as needed, and just kind of an adjunctive medication in a couple of ways. One, maybe those especially that have performance anxiety, maybe right before a test or before you go on stage. I took care of a patient who had a solo in the halftime show, and bless her heart, she just absolutely melt before she went on the field, but could take this 20-30 minutes before she went on the field, middle of second quarter, and just kind of could take a breath, take some edge off. Propranolol obviously is not going to be as strong as a benzo, but just to take the edge to kind of work through it and get through whatever that they're nervous about, especially, again, if it's test anxiety, speaking in front of others, presenting, job interviews, etc. Can take a little bit of edge off. It also helps in that second regard is to the restlessness. So those who do have more of the tremor, more of the shaky, restless type descriptions of anxiety can be beneficial. And also for when we get into antipsychotics, it can be helpful for the akathisia, which is unfortunately one of the EPS symptoms that can come off of our antipsychotics, which is again that restless anxiety type side effect from our antipsychotic. So propranolol can be a really, really good medication to add on. And yes, it can help with the aggression and violence and things like that because again, it's taking the edge off a little bit, allowing you to work through it, deep breathe, kind of get through things before reacting. Hydroxyzine, I wanted to make sure I threw that in there as well. So hydroxyzine is just, an old antihistamine, right? It is just, you've probably seen the emergency room given for nausea or migraines, or you've come in with an allergic reaction, or before you're taking your kiddo to the dentist and, hey mom, let's give them a teaspoon of this before they come and once you get here so they can get their teeth work done, their crown put in, or cavity filled, or what have not. Hydroxyzine is another non-habit forming. Again, there's no tolerance, withdrawal, memory impairments. That's really great. It can be a little bit sedating though. So that's something that a lot of times you're actually going to see it prescribed for people for bed. I think I actually prescribed it today for bedtime. So it can be a great medication to help, especially with kiddos, getting them winded down again with ADHD or so forth to help them sleep. Without having to go to a stronger type medication with more risk of side effects. Hydroxyzine, of course, antihistamines, so it's a little drying. Other than that, sinuses may be a little drier, can work really well. But what we're finding in psychiatry not only is, yes, okay, we get all these other things, anti-itch, sleep, etc., but there's some anti-anxiety. We can actually use hydroxyzine in anywhere as low as 10 milligrams up to, I think your actually Kaplan Psychic will tell you up to 100 milligrams 4 times a day. I don't usually go above 50 3 to 4 times a day. I don't want people too dried out. But we can use it to help with anxiety. There's some belief that it's doing something there due to the blocking of the histamine receptor. There's some anxiety relief. And also some interaction with the serotonin receptors from hydroxyzine. So it's a little bit different, and as your text will say too, it's different than Benadryl. And I say as little as 10 because I do have some that are more sensitive that in the small doses, or you can even take half of a 25 milligram tablet, and they're okay. They can knock off the edge of the anxiety and kind of just calm down a little, but not with the heavy sedation effect. Or maybe they have jobs and things like that they don't operate machinery, etc., and they don't want to be sleepy. So you have a little bit of wiggle room there, and ultimately it's what works best for your patient anyways. Benzodiazepines, here we go. So unfortunately, these medications can really make a huge difference if they're warranted, if they're needed. You're going to have patients who they are needed for. But they just get a really bad rep, obviously, because of all of the opioid, the stuff in the country now, and opioid crisis and the interaction with benzos, and those who are on pain management don't need to be on a benzo, and their interaction, and it's quite a mess. And a lot of these patients, unfortunately, are freaking out because they've always had, unfortunately, there have been who've done a disservice for them in really high doses of benzos, and now trying to come off of their benzos. But benzos are used for anxiety, for panic disorder, obviously for alcohol withdrawal, seizures. Some patients with epilepsy and so forth need to stay on these type medications to help people sleep, muscle spasms, again, pre-anesthesia sedation, IBS, restless leg, nausea, vomiting, multiple uses, multiple different situations. But again, just there is a high potential, unfortunately, for the risk of abuse. And we'll talk about that, because a lot of times it's also depending on the type of drug itself and what type of action and half-life is where you're more predisposed. So benzos, as I mentioned earlier, affect the GABA receptor, specifically at the benzo receptor. They increase the action of GABA, so inhibiting, slowing down the neurotransmission, and decreasing the reactivity of the brain. Now, I want to stop there for just a second. Decreasing the reactivity of the brain, okay? So this is great for someone who has seizure disorder, right? We don't want them overstimulated. We don't want that over electrical impulses and activity. However, decreasing the activity. So what we're seeing, unfortunately, now on this side of it too, is that long-term benzo use, especially high-dose long-term benzo use, actually leads to furthering depression. Makes sense though, right? You have something literally suppressing the brain, okay, from functioning, from feeling. It's just kind of, it's band-aiding it, right? Oh, I don't have to deal with anxiety. but now we're suppressing the feeling, the reaction, the normal activity of the brain, and so we're leading more likely to depression, and also more and more research is leading to Alzheimer's and dementia due to the benzos, because not being able to have that reactivity of the brain that you need. So some examples of benzodiazepines, we've got the Librium, Valium, Ativan, Klonopin, Xanax. I included a few others, of course, obviously they were in your text. However, most of the time, I will every now and then see Transine, maybe Halcyon. I will see Restoril. And some of you guys obviously who's worked maybe outpatient surgery or something like that, maybe obviously with the Versed. Most of the other ones I really don't see much in practice. For psychiatry reasons, we're obviously going to focus on probably more the Librium, Valium, Ativan, Klonopin, and Xanax. Those are the most common you're going to see. So pharmacokinetics of benzo, rapid and wide distribution following oral intake, lipid soluble and highly protein bound. Now I want to stop there because that is one thing is we're going to talk about these half-lives and these peaks of these medications, and I want you to understand that they are not just based on a half-life. Okay, let me say that again. A benzo pharmacokinetic is not just based on the half-life of the medicine. It's kind of hard just to do the rule of fives with benzos because of the lipid solubility and the protein bound. They're going to base more upon that. They have such a wide distribution that it's really hard to pinpoint. So when you see these half-lives in a minute, they're going to range majorly. Like, oh my gosh, that's a huge difference, 18 to 50 hours. Again, depending on the patient, depending on, the medication, which one, there is some variability there. The majority of these drugs will peak anywhere from 30 minutes to 6 to 8 hours. Again, such a huge variability. Wow, 30 minutes already peaking? 8 hours. Again, so we're going to learn short-acting, long-acting ones, but they are based upon that lipid solubility. So here are, now these are from the Johns Hopkins clinical guidelines. I do want to make sure I go over to understand that when you see these, yes, there's the maximums. Does that mean that that's the maximum we'll use in practice? No, not usually. Those are just maximums that they're recommending. So for example, Xanax, anywhere from 0.25 to 1 milligram 3 times a day. Therapeutic dosing is up to 3 milligrams a day. 4 is kind of beyond us. Really beyond that, what efficacy are we really getting, or are we actually risking ourselves more for side effects than we are actually helping the patient themselves? I unfortunately had a gentleman come in a few months ago that I met that came in on 6 milligrams of Xanax, and at that point, again, what is it actually doing for you? Do you even know different? Did we start at a lower dose and go up? And unfortunately, you're going to see many disservices like that with really high dosing. I had a female, my highest so far has been on 8 of Klonopin. So you never know. It may come through the door. At Librium, 5 to 25 milligrams 3 or 4 times a day. Klonopin, 0.5 to 1. 3 times a day, again, therapeutic up to 3 milligrams per day. I'm not sure why that said 20. I have seen up to 4 in practice. And what I don't understand, so Klonopin, we're about to learn in a second, is a long-acting benzo, so you really should not have to take it more than twice a day. So there's really not any more efficacy. Is it really doing anything unless you're a really quick metabolizer of taking it more than twice a day? Valium, again, is a long-acting, and they've got as 5 to 25, 3 to 4 times a day. Again, majority of the times you'll see it 2, possibly 3 times a day. And then Ativan is a short-acting along with your Xanax, and those, you will see those more often 3 times a day, if not 4, most likely more like 3 in practice, half to 1 milligrams. If you're going to see it more often, more times a day, maybe are they doing alcohol withdrawal? Are they in the hospital acutely? What's going on for the Ativan to be scheduled more often? So here's those half-lives. So alprazolam or Xanax is 12 to 15 hours. The Librium is 24 to 48. Clonazepam or Klonopin is 18 to 50. Valium is 20 to 80, and lorazepam 10 to 20. And that's what I'm saying. These range so much. So 20 to 80 on Valium, my gracious. But again, depending on lipid solubility and protein bounding, that can vary. We can still use these half-lives to an extent to kind of, okay, this is how many times a day it needs to be. Obviously, the short-acting medications, here's their half-lives. In reality, I'll tell you, most patients with Xanax or Ativan may get a 6-hour most relief from it. So you're going to see that one a lot of times prescribed more often 3 times a day. And in fact, talking with a psychiatrist who also has a specialization with addiction and substance management, actually said more likely sometimes when Xanax, if it's scheduled morning and bedtime, or Ativan, and there's not something in between or creativity, but doing a morning and maybe late afternoon prescribing, you'll actually have people begin to even start showing small withdrawal symptoms in between, and that's where it resorts to people starting to actually grasp more than prescribed and leading, unfortunately, to our abuse potential and tolerance. And so I often will say as needed twice a day on either one, and I don't like to go too much beyond that. I will do 3 times a day if I have to, but I try to be creative with my patients and say, hey, let's do morning, let's do late afternoon, and then let's do something else for bed. So then that way they're not having to take more than they need of the benzodiazepine. So adverse effects, obviously, these medications, the physical dependence is reaction. I already mentioned the long-term use with the dementia risk, depression risk. And one thing I always educate my patients is that benzos are, I hate to say this, but they're a Band-Aid. In that moment, at that moment, it's a quick help. Yes, hey, 15, 20 minutes later, 30 minutes later, I'm feeling better. I can get through it. And that's how they're meant to be. And that's how I want them to be, as a quick, I need them in that moment as needed. Where we get in trouble is when they're long-term, every day, all the time. Because when I say it's a Band-Aid, if we're still having to grasp, if we're still having to overtake, if we're running out of our medication too soon, you've got a month's supply and you can consistently keep being a week short and putting yourself through withdrawal symptoms, we'll talk about in a second, then we don't have the underlying fix. We need to work on the underlying problem. Obviously, I don't have my right everyday meds if we're still having to grasp. The benzo needs to be just as needed, just in those really stressful times, just when you're having really something maybe stressful you're walking to, or family get-together. Sometimes people have a little more trouble with family and things like that, the holidays. But having them every day all the time is just actually blanketing it, and it can actually prevent the person from working through what they need, whether it's post-traumatic stress, whether it's grief. It actually can delay, okay? It can delay grief, delay someone from working through trauma, and actually are being contraindicated now with PTSD victims. So I just want to keep that in mind. So that's some precautions, okay? Withdrawal. So benzos themselves, if we just all of a sudden we're taking them every day, we've been taking it for years, multiple times a day, and just completely run out. In a couple days, depending on that medication, which one we're taking and what's our half-life, right? We can be at the risk most for withdrawing and even seizure. And I'll have a slide here in just a second for that. So you really, really, really need to be mindful. If we're going to stop a benzo, it needs to have a gradual taper to discontinue. And there is a tapering thing posted in your module and I think the recommended is to decrease or wean by 25% per week is what your Kaplan and Sodic said. But however, I will tell you, most patients tolerate the slower the wean, the more tolerable. I will a lot of times even do that per month. Depending on the patient and what dose they're on and the situation, they will tolerate easier. I think that we provided you a PDF for about every 2-week wean. So you can kind of get an idea on how to appropriately wean a patient from a benzo and not just abruptly stop. So many times I've seen where I don't feel comfortable. Here's 3 days, boom, you're done. 2 weeks, you're off a benzo, or you've been off 3 of Xanax and you're done. It's hard, really, really have a hard time. You can actually have more rebound symptoms. So just be very cautious when it comes to safe but effective tapering and not getting patients to resort, unfortunately, to the streets or other substances to come off their medication. So effects when you're on the medication can be more drowsy, because of ataxia, you can be more tired, you can be confused. One of the things that I have to educate most on is why you'll see on the bottle, do not operate or take while operating machinery, is their reaction time. It can impair your judgment, it can slow down your reaction time when driving. So be aware, especially if you're going to mix with other CNS type depressants such as alcohol or opioids, then it may even make that worse. Our geriatric patients are more risk for breaking their hips, bless their heart, and falling because, again, it's got the risk of more of the drowsiness, the incoordination, the slowing of the reaction time and confusion. So there's more risk of falls for our elderly. So withdrawal. Now we've stopped it. We are going to go into withdrawal. Some of the first and earlier symptoms you'll see is obviously more anxious. Be irritable. Oh my gosh, I don't have my medication. I can't sleep. Hyperacusis is like when all of a sudden the sounds are really loud, everything's loud, overbearing, just I can't handle all the sounds, more nauseous, can't focus, maybe tremoring, myoclonic, even jerking of my muscles, depersonalized, feel detached from the situation, delirious, and even to a seizure. Okay, so need to be aware when was the last dose, how much were you taking, and be mindful of those seizure risks. So what we recommend is 1 to 2 weeks of short periods. If you've got to use a benzo, and you're going to see these when you're first starting an antidepressant, knowing, hey, it's going to take 4 to 6 weeks to kick in, I'm a mess, I'm having panic attacks, I've got to get to work, then a lot of times you'll see these prescribed initially as a short term. What's unfortunate is sometimes, and why we try to avoid them at all together, even in the beginning, is because sometimes once you start them, it's really hard to get a patient to come back off of them. But if you can, a short period of time, 1 to 2 weeks, just while the medication becomes more therapeutic, and there is usually no association or risk with tolerance, dependence, or withdrawal. Now, there was an exception for those who are on more short-acting medications, sometimes even taking it, which is amazing to me, but even a single dose, patients begin to kind of almost feel that withdrawal and like, hey, wait a minute, I need another one. That was so great. That helped me. Wait, I can't do without it. I'm worse. I don't know anything without it. Make a difference that quick. When the medication is discontinued, I was already mentioning, 25% a week because of these rebound symptoms. You actually can feel worse, feel like you need more of it. I can't come off of it. I can't handle this. The slower the wean, the better the tolerability. So contraindications are pregnancy, lactation, liver and kidney disease, children under 6. Let me first of all say, children, period, altogether, is it contraindicated? Absolutely, yes, okay? Especially children under 6, there's very little research that's shown safe, if any, done on children at all. That is not our go-to unless there's particular circumstances where we use hypersensitivity to benzos, and even acute narrow angle glaucoma are all contraindications of benzos. So again, pediatrics, I just use with caution, but you're not going to usually see it used with kids. You know, there might be some adolescents, there might be certain cases, severe social anxiety, we can't even get to school, or not throwing up, we can't even get to second period without vomiting. I mean, there may be certain cases, but in reality, work with their long-term medication, like their everyday medication, so that we do not have to use the benzodiazepines. Pregnancy. Back when we actually had more of the categories, benzos were considered pregnancy or category D or X, okay? So either been not studied at all, or we know there's actual detrimental effects to the baby. And so if taken the first trimester, Librium and Valium have shown to increase congenital malformations. Valium is also shown to increase fetal heart rate taking in labor. If given in large doses right before birth, the baby may suffer hypertonia, apnea, and hypothermia. If mom receives benzos therapy during pregnancy, a lot of infants will actually suffer from withdrawal symptoms. So that's something to keep in mind is, gosh, if they're consistently been on something throughout pregnancy and all of a sudden baby doesn't have that medication when baby's out, then they may, go through withdrawal just as someone who's been a heroin user, cocaine, etc. when they're born will go through withdrawal symptoms. Obviously, they always tell you, this is for any medicines, they try to avoid it in the first trimester, right? When everything's forming and developing, and for safety of the baby and healthy brain development and everything, not to be on any kind of medications. If we're only taking benzos just for sleep, should be avoided. That is absolutely contraindicated. We should not be using those. There is some controversy, obviously, whether we continue versus stop also in pregnancy. I worked with psychiatrists who felt like it was actually better for the mother to stay on the Klonopin during the pregnancy, knowing the baby could still continue and will go through withdrawal symptoms upon birth, because there was also the belief of what kind of effects to the child. Mother's always had that in the system, and now it's gone. Will there be more also stress to the baby in utero? And so that's a really interesting concept there. There's also that part of, at the end of the day, benefits versus risk, guys. I mean, untreated mental illness, are we going to resort to not getting now the care that we need and not going to the doctor because all of a sudden anxiety is hiking up? We're going to look at the streets. Is there going to be worse? Alcohol drinking, nutrition goes by the wayside. There may be more benefits than there are risks to continuing the mother of benzodiazepine treatment during the pregnancy. And so just making sure about that, making sure the mother understands about the decision, to conceive and what may be the risks, whether or not you continue it if possible. Lactation, Ativan is usually the best option due to shorter half-life, and so you're going to see that more often used. And also, I don't know if I got mentioned, but even with geriatrics, that short-acting half-life is used more often. And a lot of times, especially with women with lactating, is because you can actually kind of time it a little better. So maybe they breastfeed at 10, and hey, I'm going to go ahead and pump, and then I'm going to take my Ativan, and maybe you can kind of get around that peak side so that most of the medication is not in the milk, etc. So you can kind of time it out a little bit better with your feeding processes. Valium may accumulate in the infant system, though. A single dose is considered safe. However, those mothers who do use it regularly, baby may be more tired, lethargic. There might be some weight loss due to the Valium. Xanax is not the best choice. Xanax, there has been some research shown that it actually increases serum prolactin levels and causes galactorrhea for the mothers. And so just thinking about this discharge and things happening may not be the best for during the lactation period of time. So, and I wanted to go back and say that. So I mentioned, I might want to get you guys confused when I mentioned geriatrics, but geriatrics already mentioned that contraindicated with benzos cause a fall risk, but if we're going to use them, more often you will see Ativan used on the units because of that shorter half-life. Remember, as we're getting older and things are slowing down and our metabolism is slowing down, then you're more likely to build toxicity. So you don't want to keep long-acting. If you absolutely need to use a type of benzo for an elderly person or geriatrics, you want to stay with more of the short-acting. But to sum us up a little bit for our lecture, so continue to monitor if you're going to use benzos. Please monitor for depression, behavior changes, suicidal thoughts. Again, we are decreasing the reactivity of the brain, okay? And so please keep that in mind. Please keep that in mind, as I mentioned earlier, that not to never prescribe if they're needed, they are needed, and they can be used and make a difference, and there's a purpose for them. But also think of not necessarily self-reliance, but as needed, keeping them for those emergency situations, keep them working as they should. There's also research saying that if a patient is taking a benzo every day for more than four months or more, your body actually starts to fight the mechanism of action of the benzo, trying to wake back up the brain to feel something. And unfortunately, sometimes that's when patients feel like they need more. They build this tolerance or more grabbing. And so just keep mindful. But if you can keep it as needed, keep it only in those moments, then it can really maybe make a difference, especially even in PRN situations. We obviously pull them in when we're during acute psychosis and violence and aggression things. You're hearing, Haldol 10, Ativan 2, whatever, Haldol, you're hearing those called to help to with those behaviors. And so that there can be some really good benefits, but again, in those situations. And I already mentioned cognitive impairment. Just make sure that patients are understanding and educating the effects of the medications. But all right, I think so. That is the end of the anxiety disorder and treatment lecture. If you have any questions or concerns, please feel free to contact me. Remember, you can always message in our discussion forum for this lecture, or you can please reach out and email me, or even inbox into the Canvas, and I will be more than happy to answer any of your questions or concerns. Good luck this week. I, again, apologize for the delay in posting, but I hope you have a wonderful week and have taken some things away from the lecture and learned more about anxiety disorders and treatment. All right, y'all have a good evening.